that it's, right foot, left foot, right foot, left foot, right foot, right, left foot. About 7 times in, his left foot didn't want to go up on toe anymore. Right foot did, left really didn't go there. Did the same with heel walking. So I did heel walking back and forth, heel, 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 heel. 7 times on the left heel, he started to drop a little bit. Didn't get as much elevation left foot. Now that did bother him. So when he walked on his heels, it did hurt him a little bit. So it could have been from the pain. I had him put on shoes, do the same thing. He still dropped at about 7. And that didn't hurt him as much to walk on his heels in shoes. That I don't have a very soft carpeted floor, so that's not surprising to me that he would maybe hurt when we did that. Okay, so now we've got standing. Anything else you want to do standing? What else do you guys like to look at in a standing position on someone that has a foot problem? So I was pretty much done then. I put him in a seated position, and now I'm going to check the different things through the. So we're checking range of motion first. That's what I usually do. So I checked his dorsiflexion, plantar flexion, knee extension, hip internal external rotation bilaterally, hip flexion bilaterally. Didn't find anything that was really significant in passive or active range of motion anywhere. Looked pretty good. Okay. I then did strength testing. So you want to do the dermatome, myotome type thing, right? Dermatomes are all fine. Myotomes on strength testing, hip was perfect. Abduction, adduction, flexion, all really excellent. When I checked his knee, extension was good, flexion was good, resistance was excellent. I checked his foot, dorsiflexion was a little weak. So when I check that and I start finding weakness, I do quadrants in the lower extremity. So I want to check each muscle individually. So if I do dorsiflexion inversion and resist that, that's primarily anterior tib. If I do dorsiflexion eversion, that's primarily toe extensors and tertius. If I do plantar flexion inversion, that's posterior tibialis. Do plantar flexion eversion, that's fibularis brevis longus. So I tested those. All of them were weaker on the left than the right. That's interesting. Okay, if I was going to grade them, they didn't have a lot of pain with it. If I was going to grade it, I'd grade it at a 4 to a 4 minus. And all those, every one of them, not one stronger than that. They were all slightly weak. Okay, so great toe extension, great toe flexion, weak. Okay, toe extension, flexion, resistance, also a little weak. So we had a lot of weakness in the foot on the left side only. So my personal feeling is when I find that, I'm thinking, oh man, there's probably something going on with the neural system, right? We got a lot of musculature, can't have injured all of it, so it's got to be something that's core based. So I started looking at nerves, and so I checked his lumbar spine, no tone, no irritation, nothing in seated. I checked his some of his lower extremities where I'm going to tell you in a minute that I checked his neural channels. So I checked his nerves from foot all the way up to the back. Found no irritation in any of the nerves, whether it would be tibial nerve or the fibular nerves or at perineals, nothing, right? There was no irritation, no sciatic nerve irritation, no lumbar. So I did PA testing prone on him. And I found no tenderness of any of the lumbar segments. Remember, the PA test is primarily to tell you what segment's involved. But there was no stiffness, no hypermobility, no tenderness. Okay, so now we've got this global weakness. So it just so happened when we were sitting, I also decided that I'd check his calf musculature. And I sort of felt the muscles, and the muscles on the left were much softer than the right and a little smaller. So I measured them. And it was an inch smaller throughout the calf on the left than it was on the right. So it's wasted. That's interesting. So that's, again, we're talking nerve, but I'm not finding anything nerve. So what do you think's going on? So could he have a lumbar hypermobility or a lumbar disc injury? Well, we're not finding anything that shows that. So I did some passive mobility testing of the segments. No hypermobility, no hypomobility. The prone instability test was negative. So there's nothing there that really showed anything. But he was weaker. So He went to one physical therapist in the process of going through this prior to coming to my clinic. And you guys all have this. You know, you have people you've seen, they've gone to see other people and it didn't get better, and then they come see you and you're effective, so therefore you're the great therapist for that patient. And that happens with all of us. And so this patient did go to another therapist. They put him on a stretching program. Didn't really help him very much. So what would you do with this patient? What do you think's going on? Why does he have the issue that he has? Digest that for a minute. Let's just think about that. So I don't know. I mean, I don't have a clue. So what I did was I made an assumption, a theory, right? And the theory is that when he did his half Ironman, he overstrained his lumbar spine to the point where he had nerve irritation. Now, could that be from a disc injury? Sure. Could it be from, he's had previous disc injuries, so it could be a disc injury. Could be just swelling. Could be anything. But he probably had irritation. Does he have the irritation today? Is it still actively a lumbar spine problem? Well, no, I couldn't find anything wrong with the lumbar spine. Couldn't find anything wrong with the nerve channels. Nothing there. What's the commonality of all the weakness? What's the thing that's weak? Well, out of everything we looked at, the thing that's common is L5. So could it be L5 root that was injured at some point? Yes. Is it injured today? Didn't find anything that said it's injured today. So what is your treatment? What do you do for this patient? Okay, well, what I did with this patient, and everybody's going to be a little different. What I did with this patient is I put him on a strengthening program. But I did a little bit more than that. I wanted to get him back quicker. And so I decided to do a blood flow restriction program with him. So I put him on a strengthening program using blood flow restriction. We know that using blood flow restriction increases hormonal discharge, allows for increased vascularity, allows for increased mass faster, allows for improvement in strength quicker, and it creates this anaerobic environment that creates this hormonal response. It's pretty amazing. So I did that. You guys may not use blood flow. I'm for restriction. I'm going to suggest it's a pretty effective tool. I use it a lot post-surgically. I use it a lot with these type of conditions. And we put him on a strengthening program. Now, this is an early case. I mean, this is March when I'm recording this. So he's been working out for 2 weeks. In 2 weeks, his pain is decreased by 80% in his foot. He's actually able to run now 1 to 2 miles before he has a second pain response. That's good. Okay, so I think it probably is a strength response. I think it's a neural injury that probably caused some wasting and changes in neuromuscular control and function. And we're just making it work a little bit better. So hopefully he'll continue to get better. We'll give you an update in the future. So hopefully this was helpful, thinking through a patient case. We'll give you some more in the future. And of course, I'm going to bias these a little bit to patients that got better in my clinic instead of patients that get worse. And I don't have a lot of patients that get worse, but that happens to all of us. But I'm going to talk to you a little bit about things that are the forefront of the things we talk about in our courses. So again, my course series is Orthopedic Manual Therapy Instruction, Manual Therapy Certification if you want it, for education if you don't. I work in the Mid-South and would love to see you at some courses in the future. Thanks for joining me today, and I appreciate you being here.